Welcome to the Lung Cancer Living Room. I'm Danielle Hicks, for those of you who may not know. I think most of you in the room know who I am, but somebody online who may not know. My role here at the Foundation is to oversee patient programs and services. So anything that has to do with patient touch, outreach, education is my area of responsibility, of course, along with our amazing team, not just in programs and services, but events, development, marketing, so on and so forth. So thank you all for being here tonight. Thank you all online for signing in. Tonight we're talking a little bit about cost-related health literacy, understanding insurance options, and treatment-related financial planning. I don't know if anybody knew or has known historically that oncology financial navigators were a thing, or that there was an option or resources out there available to you. I do know that a lot of you that I have spoken with over the years, you've had conversations with either myself or Michelle about maybe some challenges with coverage, co-pays, drug access, so on and so forth. So we have Clara Lambert, who's an expert in this field. She is an oncology financial navigator at the Cowell Family Cancer Center in Michigan. So welcome, Clara. Thank you for being here tonight. And then we also have Wayne Young, who those of you in the room know, and those of you who have signed in before may know. He is a regular, he and his wife Rebecca here at the living room. He is a caregiver and is here to talk about some of the challenges that they have had and use sort of his experience to help educate others on how to navigate this process. So welcome, Wayne. And with that, I'm going to jump into introducing Miss Clara. And I'm going to start by asking you to sort of share your story and how you got into this space to begin with.
So my story is I was actually a caregiver. My husband was diagnosed with lymphoma when he was 32. And we had 3 pretty young kids. I think the day he had his surgery was my son's first day of kindergarten also. So I went through the experience as a caregiver and had to reach out. There were no financial navigators at that time. And so I had to figure out how to pay for Rituxan, which is a Genentech product, and they're very, very generous. There's copay cards for that, and we were young, so we didn't have to deal with the Medicare regulations, so we were able to get help directly from the company with copay cards. But and just other things, like I remember it was right at the beginning of the school year, and so treatment went through Christmas, and just different foundations and organizations out there. And even my husband's a firefighter. And so just the community rallied around us, our church, all the fire departments in the area. And so I was pretty proud of myself for what I was able to do for our family. And I, in the middle of it all, I had lost my job. And so then I started working at the hospital in registration and insurance. And I was like, wow, I could share what I did for myself with other people. And it took me about 10 years to get into this field, but here I am. So that's my story. My husband's a survivor and no cancer, so his was curable. So
that's great. So. I think there's a just in talking with patients over the years, there's this sort of lay understanding. You know, number one, when you're diagnosed with cancer, you expect that your physician and who you're talking to is going to know everything there is to know in order to treat you properly, which, as we know, is not always the case. And then B, especially if you have insurance, that whatever it is your doctor feels is best for you is going to be covered because you have cancer, and of course that's going to be covered, right? And that's not always the case. So I think there's this, it's kind of this double whammy for a lot of patients when they're diagnosed. A, the diagnosis itself, and then B, not being able to get access. So how do patients, this can be sort of a twofold question, how do they get access to you or know that you're there as a resource and available to help them? And then B, once that happens, what does your first initial sit down look like with them? What sort of questions do you need to ask them in order to best understand what their needs might be?
So we have a handful of ways that they can access me, but we try to look for some red flags. So if somebody has Medicare with no supplement or nothing secondary, that's a red flag because they have a 20% co-insurance and there's no cap on it. So we definitely want to talk to those people. And then we also look to people who have high out-of-pockets, high deductibles, different things like that that we think, are going to warrant needing help. We also have a patient notebook full of resources that we give to every patient, and our card and our bio and information about us is in there. So we can either reach out, and we try to be proactive and help as many people as we can before they need us. But then also, if somebody does run into a financial situation, then we're in the resource book, so they can contact us.
Interesting. So is this something that's actually flagged in like EMR by the clinician or the nurse navigator or something?
Yeah, so the nurse navigators, we have primary nurses that work directly with the doctors, insurance verifiers, our social worker. So pretty much anybody, even the infusion nurses, if somebody says anything about having financial issues, they flag it for us.
Wow. Wow.
So we have a pretty big caseload. Sometimes we can't keep up. It's so busy. But so when I sit down with a patient, they've already gotten the bad news from the doctor. And so we talk about their treatment plan. And I think one of the very important things in that sit down is to talk about their insurance and just make sure that they understand what their coverage is. I've found that insurance has made some major changes just in my lifetime, because it used to be when you had insurance, then everything was covered, and that's really not the fact anymore. There's a lot of patient responsibility, and it's covered. However, you have $1,000 deductible or something like that, and so you're going to have a higher responsibility. So I see Sally has a question.
How common is a financial navigator? Are they at all medical facilities or only certain ones? And how do you access them?
So financial navigation is a pretty new career field. I would say it is about 5 to 10 years old. It is, I think one of my hopes is that it's going to be more common, but not all cancer centers have financial navigators. Most hospitals have financial counselors, and financial counselors usually help people apply for Medicaid, help people apply for the hospital assistance programs. And then as far as the pharmaceutical information, a good financial counselor might dig in and be, proactive and try to help with that. But a lot of times you end up having social workers, nurse navigators. I know of some places that have pharmacy techs in the specialty pharmacy or pharmacy techs that do it. So it's not something you're going to find at every facility.
Well, and that's a challenge in and of itself, because if you understand one insurance plan, then you understand one insurance plan.
Correct.
Right? Because they're all so different.
Well, so back to that first sit down then. So I think it's important, I try to study the different insurances, and sometimes if there's a new one, I'm going to learn it right along with my patient. But I think it's important to be prepared for that first visit, understand their insurance coverage, help them understand their insurance coverage and what it's going to pay for and what their patient responsibility is. And then we start talking about the different types of assistance that we might be able to find. One of the first things, I think one of your questions, I'm going to get into it, is about insurance optimization. And that's taking financial navigation just a little bit further, really. Not all financial navigators are going to do this, but if your insurance isn't really the best, then we're going to be doing this again in a year. And so it would be really good so what I try to do is, if there's a way that we can solve a situation at the next open enrollment, then let's go back on, if you're a Medicare patient, let's go back in and put the drug list in and look and find the best plan for you and your situation. And I really think if you're on Medicare, you need to do that every year. Don't just go with the status quo of what you have.
Wayne, do you want to share a little bit of your story and your experience?
Yeah. Well, my wife was diagnosed with 3B lung cancer late in November 21st. So we were put in a unique situation where we had the month of December to look for new insurance because the year was rolling over. And we were also in the process of looking for additional hospitals for second opinions. And we found several, each hospital has their own different policies. So for example, one hospital wouldn't accept a policy from Covered California or Obamacare. There was one hospital that wasn't going to accept insurance from an individual plan, but only through an employer. And so we were doing all of this insurance shopping with my sister, and this is all through individual insurance. And we're trying to have as much of a contingency plan as possible. Your question earlier about getting out of the system or having that special enrollment, you can get into a special enrollment when you get married, divorce, when you move. But we found that if you're lucky enough, you could always start a new business, a small business. And then as a small business, you could apply for a private group plan that would.
So you either have to get divorced,
You get divorced,
start a new
find
business.
yourself get married, move out of state,
Yeah.
or you could start a small business and get a small business insurance plan. One thing about shopping for, there are different tiers, and what we found out was that at some point, your out-of-pocket maximum pretty much evens out. So you might be paying lower monthly premium, but all of the other costs start to add up, and they all pretty much come out about the same every year. The one interesting thing that we found was that for many plans, the prescription medicines do not count toward your out-of-pocket maximum. So that's something to consider, because some of the drugs start to get really expensive, and if they don't contribute to your out-of-pocket maximum, it's going to get more expensive for you on a year-to-year basis.
So this was all after Rebecca was diagnosed. So you're going through this sort of, mental shock and anguish right along with her and the family, trying to, wrap your head around the diagnosis, and now you're trying to have to navigate how to pay for the care. How much time did you have to spend learning all of this?
Well, fortunately, my sister was able to help me. She does the benefits for our small company, but there was a lot of almost a full-time job for us up until she actually got treatment. I think Dave had a question about whether or not the doctor should tell you what's covered and what's not covered. That's really case to case. Some doctors were really great in saying, hey, this procedure is covered, it may not, then you will have to fall back to another one. We had another doctor who just didn't even know. So, for example, the radiologist, oncologist had prescribed an IMRT treatment for her, and we found out the day that she was going in for her first day of treatment that the insurance denied the coverage. So that was really frustrating, right? Because we were mentally geared up to do something, and they just didn't tell you or didn't give you any kind of heads up.
So you didn't know it till you got to the appointment?
Well, they called
Or they called you before the appointment?
Yeah, before the
same
appointment.
day.
On the same day.
Yeah.
And we spent about 2 weeks trying to get this approval to get this treatment plan approved, which they did. And I heard the story that you mentioned about your friend. And I think a lot of insurance, their default is to always just to deny the first claim, and then you have to go through the appeal process, which can take some time. And unfortunately, we were in the middle of the holidays, so not a lot of people were there, and so it just dragged on. And our nursing staff was really wonderful, and they literally were on the phone for hours just on hold to get to somebody. And that's their full-time job. And that's and they treat, 20 or 30 different patients a day. So you're not going to be able to get the care that you need from them. So we had to, do it ourselves. We had to be on hold for an hour at a time. And we were able to coordinate. When we got somebody on the line, then we conferenced them in. And so we're able to do that when they couldn't.
I can't, every time I hear one of these stories, I get more and more angry because I don't feel like it has to be like this. I feel like, we've got these big letters on the wall, right? And all this hope, and we have all these amazing treatments out there to help patients, to cure patients, to chronically manage patients, to maintain quality of life. All of these things that, in my opinion, are due every human being because it's available. And the fact that people have to beg, borrow, steal, and fight their way towards these treatments makes me absolutely insane, especially when we look at the decision makers behind sort of what is and isn't covered. It's just, it makes me crazy. So that was just my little quick rant. But it makes me really grateful that there are people like you out there to help navigate this process.
Actually, we have a lawyer friend, her name was Risa Donlan, and she pointed us to an organization, the California Department of Managed Healthcare. They're basically a watchdog agency that monitor all the insurance companies. And they have lawyers and doctors on staff. And we were actually going to have them help, be our advocate to get things streamlined and rolling along. But, on that day, we were actually, our doctor made contact and they got the approval. So we never took advantage of that. But, they have a staff who's just dedicated to getting approvals and, making sure that the insurance.
And every state has that.
Yeah, I'm sure, but
And
it's
they all
even,
have different names.
I'm sure, right?
Yeah.
So now let's go on to some of the, we started talking a little bit about some of these buckets. And you guys have heard us talk about this in here before, some of you, not all of you, these sort of lung buckets. There are groups out there, not just large companies like Lockheed, but nonprofit companies, whether it's PAF or Chronic Disease Fund or others, they are in the business of trying to raise these buckets, that's what I call them, I don't know what they call them, of money for different disease sets to go ahead and provide this type of assistance. But to your point, Claire, most of them, because the lung buckets don't tend to have, they have what seems like a lot of money when you
Seems like a
hear
lot of
about
money.
it.
But how much
The
does
need is
Tessiva
so high.
cost, or
Yes.
Opdivo, and
Can you
all
talk
the
a little bit
different-
about these groups?
So these groups, they are foundations, and basically there's a rule out there that the pharmaceutical companies can't directly help patient with government-funded insurance. So that would be the Medicare, the Medicaids, the VA, TRICARE. So these foundations are set up and basically treat everybody the same. So you have to fall within an income guideline and different other steps. And they do it disease-specific. So there's probably between 5 and 8 different foundations. There's probably about 5 of the more common, and then 3 that we reach out to for less common diseases and that kind of thing. But yeah, the lung cancer buckets have been pretty dried up.
Yeah, I tell patients all the time, and because there are some great organizations out there, but that if you literally haven't applied January 1st, like at the ringing of the bell, to your point, what did you say, 90?
It was 90 minutes. It was about 3 weeks ago, so it wasn't even in, in January.
That's when they started.
It was
releasing the money.
open.
Yeah.
I got an email that was open by the time I got a hold of my patient that we needed to apply. They'd already closed up.
Yeah. It's definitely a challenge, and we work with a lot of these groups, and we've had these conversations to try and help alleviate this. But as we all know, especially when it comes to lung cancer, fundraising is not where it needs to be in order to ensure that those sort of buckets stay filled. We already discussed a little bit about when patients should consider changing their insurances. For someone who may not really be paying attention to that, or for someone who's in, let's assume, like a, well, even like a Kaiser situation,
Oh, yeah.
especially at diagnosis, how do they, if they want to step out of the Kaiser system, how does one do that once they've already been diagnosed?
Yeah, so what I'm understanding when you say the Kaiser system is they need to seek their medical care. They have benefits one way within Kaiser, and then basically out of network if they're outside the Kaiser system.
Basically out of network.
Okay, so it depends on if they're going to be able to get the best treatment they can going through Kaiser. If they want to step out and get a second opinion, that's a little more difficult. I would recommend to them to look and see if there's a special enrollment period. And sometimes if you get married, you know, sometimes there's different things that can get you into a special enrollment period, but for sure, open enrollment every year, every insurance. You know, whether you're through an employer, through the marketplace, or your Medicare, there's an open enrollment every year. That might be the best time, but see, if you're in a stepped insurance like that, your premium is going to go up if you want to step outside also.
What do you see in the future of this space?
So I see financial navigation is becoming more recognized as a career field. And then as we do, we're really reaching out, doing a lot more training, trying to find technology to support us, create technology to support us. And I think you'll hopefully see things that more grand in that department.